Thank you, Enrico, Mr. Chairman, and thanks, Manos, again for the kind invitation. So my topic is really actually controversial. Let me introduce my new job location. I moved to Brescia, which is in the north of Italy, close to Milano and Verona. And this is my new hospital, and this is my new email address. My topic is, as you know, the technique described the first time in Japan. At that time, the reverse total shoulder arthroplasty was not allowed in Japan, so they developed a technique, an alternative technique to treat this massive, irreparable rotator cuff tears that impaired function in the patients. Shoulder function. So the rationale of this technique is to recreate the superior capsule to keep the humeral head reduced into the glenoid socket by attaching a tissue between the glenoid and the greater tuberosity. And differently from the bridging technique, in which some residual superior instability and high retear rates were reported, with the superior capsule reconstruction, the superior translation was restored, so the position of the humeral head was restored. And the thickness of the superior capsule, according to recent anatomic studies, is really thick on the humeral side, but this is well recognizable even on the glenoid side. It's almost 4 millimeters on the medial side and almost 9 millimeters on the lateral humeral side. So the superior capsule exists and occupies almost the entire footprint area of the supraspinatus tendon. So the indication actually for this procedure are massive contracted tears of the superior cuff, basically superior spinatus and the superior part of the infraspinatus, with a superior migration of the humeral head with an intact or repairable subscapularis, an intact teres minor, no severe rotator cuff tear arthropathy. In case of revision cuff repair, this is still questionable, is under investigation, and they say as well with the pseudo-paralysis, because results are promising according to these authors, but some other results are controversial. So the technique as based on the position, on the placement of 2 or 3 anchors on the glenoid side and the 2 anchors on the lateral side on the humerus. Then we measure the distance between these attachment points to size our patch, which is a fascia lata or allograft or other devices. Then the sutures are retrieved outside of the lateral cannula and loaded over the patch. Sutures or tapes, depends on the different techniques variants. Then the patch is pushed inside the subacromial space and fixed on the medial side first, and then on the lateral side, as fixed with a 1 row or single row or double row technique according to different surgical variants. So the thickness of the graft is actually a very important issue in terms of efficacy. And actually, biomechanical studies show that graft should be 7 to 8 millimeter thick because it provides a greater stability than a 4 millimeter thick graft. Regarding the position of the arm during fixation, it should be placed at between 15 and 45 degrees of abduction, according to some recommendations provided by Dr. Miyata as well. So different technique modifications were reported in the literature in the last years, according to the graft choice, addition of micro and nano fractures on the greater tuberosity, number of anchors, depending on the number of rows that you use on the lateral side, so medial and lateral fixation, suture configuration, use of tapes or sutures. But the rationale of the technique basically remains unmodified. Is there an optimal graft? Fascia lata is still an option. Extracellular dermal matrix was suggested. The long head of the biceps tendon is another option, recently reported in the literature. Regarding pros and cons, fascia lata autograft for sure is available, and from a biomechanical standpoint was demonstrated to restore complete normal kinematics. Normal kinematics of the human head, and compared to human dermal allograft. The problem is the donor side morbidity, although Dr. Azevedo showed a minimal invasive harvesting technique with very small incisions on the thigh. For dermal extracellular matrix, you have no donor side morbidity for sure. Animal studies showed very good results, but there is a cost, additional cost, of course, despite the number of anchors, of course. So results, functional outcome improvement was reported in the literature during the last years with a clinical success rate up to 70%, and the pseudoparalysis was reversed in over 90% of cases. And high rate of return to recreational and physical work, recreational sports and physical work, according to the report by Dr. Miata again. And imaging studies show that graft repair rate approximating 30%, with a consistent and lasting increase in acromion human distance. Biceps autograft, as I said, is another option. Recently, several different surgical technical notes have been reported in the literature with the use of this surgical procedure. The advantages of this technique is that the biceps remain vascularized on the medial side because it remains attached on the superior glenoid pole. It can works as a bridge between the calf and the humeral head, and it can restore a sort of superior capsule and can be used as augmentation and superior capsule reconstruction at the same time. And it can be used also during a repairable a procedure for repairable rotator cuff as an augmentation. So it's a potentially successful technique. The technique is very simple, has no additional cost because you have no anchors for the medial side, and you just use 1 or 2 anchors on the lateral side. So the biceps is retrieved and fixed on the humeral side, on the humeral head, is rerouted posteriorly to the biceps groove and attached with 1 or 2 anchors. And then you can go on with your partial or complete repair, or just approximating the posterior side of your irreparable rotator cuff tear to the biceps as well. So all the sutures are passed through the biceps, and then the biceps is cut, and the proximal stump is free to be routed posteriorly to mimic the direction of the supraspinatus, and is attached over the supraspinatus footprint. The arm is maintained in a slight abduction between 20 and 40 degrees of abduction without traction. And then the residual part of the calf can be reattached to the biceps as well. So results are promising, actually, even if we have just a case series that reported improved functional score, improved range of motion compared, active range of motion compared to the preoperative condition, pain relief, and imaging showed almost 80% of structural integrity at 2-year follow-up. Advantages: we have no donor side morbidity, we shorten operative time, and we have no additional cost. Of course, availability of the biceps is a minimal requirement, because if we have a previous tear of the biceps tendon, this technique is not suitable, and the mechanical strength of our repair should be demonstrated. So what's in the pipeline? Actually, some others, including myself, are using the semitendinosus for recreating the superior capsule, different configurations. This is a one configuration. Actually, I'm using a reverse. This is a reverse V-shaped. I use a V-shaped, so I use two attachment points on the glenoid and one or two on the humerus. And synthetic patches are actually under investigation to recreate the superior capsule. This is an animal study, actually. The results are unpublished and confidential, but this is an animal study on an infraspinatus model. And as you can see in the animal, in the sheep, the superior capsule is well represented and completely separated from the infraspinatus. So the synthetic patch is used to restore the superior capsule. So finally, superior capsule reconstruction is an option also as an augmentation for repairable rotator cuff. Some experience has been reported in the literature that restore stability, improve functional and anatomical outcomes, and over-the-top incorporation provides a very good repair and very good results. So in conclusion, is it a revolution? I would say yes. Is it? Potentially it can dramatically lower cuff retear rate, also in a repairable cuff. And best results are always achieved actually based on the correct indications. So the patient profile should be carefully selected, and the surgical skin experience are still crucial for this technique. Thank you very much, and I invite you all at the next Specialty Day meeting in Madrid of the ESCA that involves ESA and all the other sections of the society. Thank you.